So thank you very much indeed. It's a great pleasure. I'm Jeremy Chataway, and to my left is Dr. David Lynch. It's a delight to be able to address you this weekend at the Alex charity group. David and I, with many others, have been working together at Queen Square on adult onset leukodystrophy, and we'll describe some of the work we've been doing. But what we're going to do over the course of the next 20 or so minutes is give you an introduction to leukodystrophies, what's going on, and then we'll start to give some examples. We'll look at treatments, symptomatic treatments. We'll start to talk about emerging disease-modifying treatments, and then our plans for the future. So again, it's a great pleasure for Alex to invite us to speak. And so David and I will do a bit of a double act, but first I'll hand over to David for the next slides.
Okay, thank you, Jeremy. So the first thing that we wanted to talk about today was, what is a leukodystrophy? Well, they're a large group of disorders where the main problem lies in the white matter of the brain. So the breakdown of the word is that leuko means white and dystrophy means imperfect growth or faulty. And in the brain, we have a large number of nerve cells, and those nerve cells have to talk to each other. They do that by sending sort of projections or wires out, and the signals are transmitted through the wires. And the wires, just like wiring in an electrical cable, will have insulation on it. The nerve cells are covered with something called myelin, which helps the signals get through efficiently and quickly. And problems occur when the myelin is damaged. So when the myelin is damaged, or if it doesn't form properly in the first place, then the messages between the nerves don't get through very effectively. And then you have a breakdown of communication between different parts of the brain. What this does is it causes problems with movement and speech, balance and memory. And this is an example of a myelinated cell, so a cell that's covered in myelin, and where the myelin is damaged, and you can see that the nerve impulse doesn't get through where the myelin is damaged.
And would it be fair to say, David, that the myelin is a bit like the sort of insulation of the electric wire? Is that
exactly
what occurs? Yeah,
exactly.
Okay.
So why do people develop leukodystrophy? What are the causes? Well, some people develop a leukodystrophy because the myelin fats that make it up, the insulation and the proteins there, don't form properly in the first place. Sometimes it's because there are enzymes in the body that break down toxic substances, and if those enzymes aren't working, the substances sort of build up in the myelin and that damages it. And sometimes a leukodystrophy is caused because there is difficulty transporting important chemicals inside cells, because some of these cells are very big and they need to send messages from one end of the cell to the other. So there are a big variety of causes of leukodystrophy. Over to you, Jeremy.
Yeah, so as David had just said, there's a large variety of leukodystrophies, perhaps 100 or 100 plus. So many start in childhood, and as you can read here, these are when particularly the myelin doesn't form properly, that sort of rubber insulation, or toxins accumulate. But in fact, we know, and increasingly now, that a leukodystrophy can develop at any age, from childhood to adulthood. And we particularly become interested in the adult onset leukodystrophies. So here we have an MRI scan. So I think probably many of you will be familiar with scanning. So magnetic resonance imaging, MRI, is the modern technique to have a look at what we call the central nervous system in particular. That's the brain and the spinal cord. And so here we have cross sections, a sort of cutting cross horizontally inside the head so that we can see what's going on. And on the left, as you see it, is a normal brain scan. So we have the normal folds of the brain, and we have what we call the grey matter and the white matter, but they come out in slightly different shades of grey or white here. Surrounding them, which comes out as black, is the spinal fluid, and then that drains into the middle of the brain here, and that's what we call the ventricles. So that's a normal example on the left. Let's turn to the the right. And I think what you can all see immediately are these areas of whiteness, which are particularly at the top and bottom of these black structures, the ventricles. So this would be indicative of something going on in the white matter, i.e. a leukodystrophy. And indeed, there are many, many patterns that we see, and part of our analysis or diagnostic process is to look at the MRI scans of people who may or do have a leukodystrophy to try and determine exactly the cause of it. And that's a real integral part of what we do as part of the clinic. So we can see the normal, and then we can see a leukodystrophy scan there. And so I don't know, David, if you want to take us through some of these names, as it were.
Yeah, so some of the conditions that we see in adults are the same conditions that the children doctors see, that the pediatricians will see. So there's the same things like adrenoleukodystrophy, that can occur in children, in boys or in adult men, or metachromatic leukodystrophy. But there are some conditions that we see that are very specific to adults and never develop in children. And so it's important for us to be aware of those, because up until recently, most research in this area has really focused on children with leukodystrophy because it's much more common in children, as we know. And so something that we do is we look at particularly adult diseases like CSF1R or CADASIL, for example. And we're going to talk about CSF1R a little bit in detail as an example. And one question is, how do children and adults differ when they have a leukodystrophy? Well, the main thing to be aware of is that when a leukodystrophy affects a child, it's affecting a brain that's developing and forming over time and maturing, whereas in an adult, the brain is fully developed and symptoms begin. So the symptoms in an adult and a child can be very, very different.
Yes, so as we said, they can be very different. A developing brain of a childhood and the developed brain of an adult. So for example, here we have in children, there may be delay in what we call the milestones. So the normal ages, as it were, when a child would walk and talk. So there might be some delay in that. There could be other issues, difficulty feeding. There may be epileptic attacks, we call seizures. Sometimes problems with the joints and the arms and the legs. And sometimes the behaviors themselves of a child may not be within the normal limits. And that's how a leukodystrophy can present in a child. But if we turn to adults, then we just see a sort of different range of possibilities. And as adult neurologists, generally, we're used to thinking about these types of symptoms. So, for example, problems with the memory and the thinking, that's what we call cognition. Sometimes there are frank psychological or psychiatric changes, and then difficulty with balance or arms or legs, or even a slowness. So some conditions, a person may look as if they have Parkinson's disease, and then there can be bladder and bowel symptoms. So you can see here just from this brief list that adults with leukodystrophies will look different from children with leukodystrophies, and that's part of the challenge, because in fact there are many other adult neurological disorders that can produce some of these symptoms. And so when myself and David are thinking about the diagnostic process all the time, we're trying to filter out what the symptoms could be due to. Are they due to a leukodystrophy, or indeed some other condition? We've mentioned Parkinson's disease, we could mention multiple sclerosis, so on and so forth. So we spent a lot of time trying to work out the exact diagnosis, because of course that will help us in terms of the treatment path. David.
So I just wanted to talk about one example of a more common type of leukodystrophy that only occurs in adults, and it's called hdls. Stands for hereditary diffuse leukoencephalopathy with spheroids, which is just a description of what it looks like when we look down a microscope slide. It's not particularly important, but the name of the condition is hdls, and it is one of the more common types of leukodystrophy that affects adults. Probably about 10% of adult patients have this form. It's inherited, like all leukodystrophies are inherited. And in this condition, it's inherited in a way that's called autosomal dominant, which means that the children of affected patients have a 50% risk of developing the condition themselves. And it's caused by mutations in a gene called CSF1R, which I'll talk a little bit about. So I just wanted to describe what the typical patient might look like with HDLS so that people can get an understanding of the kind of difficulties someone with HDLS might have. So the onset is very variable. It can be any time from the age of 18 up until the 70s. And symptoms can be variable even in the same family. So even if you have a parent and child or a brother and sister who have the same genetic problem in the CSF1R gene, their symptoms can be very different. Some people have no symptoms and they can reach an old age with no symptoms, even though they carry the same genetic problem. But some people might be severely affected. The symptoms are typical of what you might see in an adult who's affected with the leukodystrophy. So sometimes problems with mood or anxiety or depression, sometimes memory and thinking problems can happen, and then stiffness in the arms and legs, balance problems. And sometimes HDLS can look a bit like Parkinson's disease because it can make people a bit slow in movement as it goes on. And also bladder involvement can happen and make people get bladder urgency. And these symptoms usually progress over a period of time, over years, usually sort of a 5-year period at least. This is a typical scan of somebody who has HDLS, and it has some very unusual characteristics that are helpful to us to make the diagnosis, but they're not so important for the purposes of today's talk. What's the basis of it though? Well, CSF1R, the gene that is defective in HDLS, is essentially a traffic light that sits on the surface of a cell called microglia, which are really important cells in the brain. And microglia have a function to digest or get rid of waste materials or infectious agents that are in the brain and keep the brain sort of clean and tidy in a way and maintaining brain health. So if microglia aren't working well, then it can cause trouble in the myelin. Over to you, Jeremy.
Okay, yeah, so David nicely illustrated an example of a particular adult onset leukodystrophy, just to kind of give you a flavour of the sorts of problems. And so we'd like now to talk about, well, what can we do about it, looking at the symptomatic side. And then David will talk about, well, can we modify the disease, or what are the early treatment or trials going on? So we're going to look at it two ways round here, and I will start off. I think it's so important because these are very complicated conditions to have what we call a multidisciplinary approach. So many people who are skilled and who have knowledge can come together to discuss exactly what is the right treatment. And we've given you some examples here. So for example, our colleagues in nursing, in physiotherapy, occupational therapy, perhaps neuropsychology, when we think of the memory, maybe bladder function. It's really important for people to come together with knowledge of these conditions, because if you like, the sum of the parts is more than the individual components. And we spend a lot of time really thinking this through so we can get the best outcome that we want for our patients with leukodystrophies. So we're just going to discuss, I think, again, you don't, of course, have to remember this, but just to kind of give you some flavour of the sorts of treatments that will apply to different problems. So stiffness or spasticity can be quite common generally in neurological situations, but we see it also particularly in leukodystrophies. So the treatments could be simple, like stretching or physiotherapy exercises. It could be some additional external support is needed for some splinting programs. And then there's a variety of medications that neurologists and doctors use to reduce down the spasm and the stiffness. And generally, actually, these are really quite effective. So I suppose what we'd say here is don't hesitate if you've got excessive spasticity that's really impacting a great deal on day-to-day living, don't hesitate to seek help, because there's quite a lot we can do here to improve the situation. And then in certain situations, there are more advanced treatments like botulinum toxin or sort of sometimes pumps of baclofen. But the basics can certainly be applied by your neurological team and can really make a difference. So we encourage people to seek help for this. And then again, another problem which we think we can really help with is the bladder issues. So sometimes going more often, too frequently, or getting up at night 3 or 4 or 5 times at night, or having to go very quickly, so-called urgency. Lots that can be done with simple medication and simple ultrasound scanning of the bladder to improve the situation. So please don't suffer in silence, because these are not dangerous treatments. They are available, and most clinical care can supply it. So we should be able to do something about the bladder situation, and indeed also the bowel situation if that's misbehaving as well. And then pain, so nerve pain or joint pain or stiff muscle pain really can be a pervading problem here. And again, like those last 2 areas of spasticity and of bladder and bowel problems, there's a lot we can do from simple things or simple painkillers, naproxen, ibuprofen, all the way to nerve painkillers, which are normally very well tolerated. So I would really like to encourage you to seek advice so that we can help here. So nerve pain is definitely treatable. And then we've mentioned here sleep. It seems a simple matter, and perhaps you say, well, there's no problem here. But we do know that with our leukodystrophy, or some of our leukodystrophy patients, then sleep is a problem. And again, moving from the simple to the complex, there's quite a lot to offer here to discuss with your team. So that can certainly be, and of course, a good night's sleep will make all the difference the next day in terms of reducing the fatigue levels, giving you more energy, and reducing the impact of the condition. Sometimes, occasionally, seizures or epileptic seizures can occur. I don't think it's common, but we certainly see it in the adult leukodystrophy service. And there's a wide variety of fairly straightforward medication which can really sort out these seizures under the expert help. So please don't just put up with seizures or repetitive seizures. There's a lot that can be done by your team here. And so I'm going to end that section talking about the different symptoms. And Dave is going to talk about some coming science and more advanced issues.
So Jeremy talked about the treatments of symptoms in leukodystrophy, but a different aspect is whether we can affect the disease itself, the underlying problem that's causing the disease. Because this is a sort of area that's research has recently started in, most of the treatments are experimental, I have to say, but there are some trials launching in the next 1 or 2 years to be aware of. So some people ask us about stem cell transplant, HSCT, and that has been used. We know that that is used widely in adrenoleukodystrophy in boys, and it has been used in a few other forms. For adults, the most relevant condition apart from adrenoleukodystrophy would be hdls, which is the condition I mentioned earlier. And there have been a few cases of stem cell transplant that have been successful. So this was a published report of a patient who had a stem cell transplant with hdls. And what it shows is that some of the typical MRI changes of hdls here, if you can see on the left of the screen, are improving over time. And this is 24 months after the stem cell transplant. And you can see that this brightness in the brain is decreasing, which is becoming more normal. And this patient did stabilize after a stem cell transplant. So in some countries, they're moving to do this more for hdls. But that being said, we have to be aware that this is an experimental treatment for hdls. It's not a standard treatment, and it's only been performed probably 10 or 20 times throughout the world. So although it can slow progression in some patients, and we've seen some patients stabilize after a stem cell transplant, we need to be aware that it's experimental and it can come with significant risks. So at the moment, we'd say it's early days regarding stem cell transplant, but it is something that we're keeping in mind and we're watching as evidence comes out from colleagues around the world. Something that is exciting is the potential for more targeted gene therapy. And there will be some trials coming in the UK for CSF1R and Alexander's disease in the next year to 2 years. A CSF1R or hdls trial is likely to start in the UK next year under our supervision. And Alexander's disease trial is likely to start sometime after that as well.
So we've given you a flavour there of symptomatic treatments and obviously the very exciting but early prospect of disease-modifying treatments. We came together at Queen Square, the National Hospital, maybe about 10 years ago as a group to put our minds together from different aspects, from the clinical side, from the genetic side, from the metabolic side, from the neuroradiology side, to see if we could improve or streamline or make more efficient the diagnostic pathway. Because, as you may have gathered, leukodystrophies are rare. They are rare diseases, both in children, but also in adults. And certainly as neurologists, what we were finding that it was taking many, many years for patients to come to an exact diagnosis, and going through many, many investigations. Some of them were repeated investigations, some of them were very invasive, and you can't get more invasive than a brain biopsy. Sometimes necessary, but sometimes not. So we sort of, over the last 10 years, have really sort of formulated ourselves together as a team so that we can put together a more efficient diagnostic and then management process. And we meet regularly and we talk about with consultants and doctors, both nationally and internationally, about their patients who may have or do have adult onset leukodystrophies to try and sort of get there quicker. And certainly, of course, it's coincided with a genetic revolution. And David might talk about that in a moment, which has made a dramatic difference to some of the diagnostic processes in this group of conditions. So we come together, therefore, as the Queen's Square Adult Leukodystrophy group. And as I've said, we are many specialties and we take referrals and we generally look at what's happened to the patient by talking to their home team. And then we will go through the investigations meticulously, both in terms of blood tests, scans, and other more advanced investigations. And then we will, in particular circumstances, see the person face to face. Sometimes we need to, sometimes we don't need to. Of course, in the time of COVID, we're very careful with that, but we have that capability as well. And we put together our thoughts, if you're interested in this review, which I think came out a couple of years ago. And you can see by the numbers of people there that the kind of concerted effort that we put when we come to think about each individual person, both diagnostically and then moving on as to what we should be suggesting. And I don't know, David, before we come to this slide, if you want to talk about the genetic advances and that, because I think that's revolutionized our diagnostic process.
Indeed, well, when the group was started, it was quite difficult to do genetic testing, and we generally had to do a single gene at a time. And as we said at the start of the talk, there are at least 100 different genes that can cause leukodystrophy. So if you have to test them one at a time, it's takes a very, very long time before you get through them. And it was very expensive to test them at that time as well. So this is why people had this huge delay. But over the past 5 to 10 years, changes in how we do genetic analysis and changes in computer power really have meant that we can do multiple tests all at the same time. So in one sample, I can sequence 100 or 200 or 1,000 or 10,000 genes, depending on what I want to do, all in the same day. And so with better computing power and understanding of genetics, we've been able to speed up this process for many, many patients and come to a diagnosis a lot faster. And that's been really good for patients, I think.
Yes, indeed. I mean, I think certainly in my observation, not being a genetic expert, David and Professor Holden are, it's been exceptional, what has been achieved, with much more to come. So, as you see, we put ourselves together and we sort of honed down, but we wanted to turn this into an NHS National Commissioned service. And so we've been working with the Department of Health and also with our paediatric colleagues probably over the last 3 years. And David, I don't know if you want to talk about the work you were doing to apply for the commissioning process.
So I think this was a great success of the our colleagues in child health, with ourselves and with colleagues that we have in Birmingham too, to try and persuade the government that we should be investing in patients who have white matter disorders, who have leukodystrophies, and really providing a top-notch service. Because although we offer our service here at Queen Square, we're aware that there are patients around England and the rest of the UK who never come to see us and aren't referred to see us. And so in a way, it's a little bit patchy, depending on where you live, of who you might end up seeing. And so we wanted to improve that. So we spent quite a long time persuading the government that they should fund a national service. That would mean that everyone in England who is affected by a leukodystrophy would have the same access to expert care and help. And that was successful. And we got word that it was approved just before COVID struck. So obviously there's been a delay in that being rolled out, but it looks like it's going to be rolled out next year, so 2022. And that will be a service that anybody with a leukodystrophy can access. There'll be probably one centre in London and one centre out of London for people who don't live nearby.
So we're just waiting for the results. We put a big application in from the National Hospital, and so we'll wait for the results of that competition, I guess maybe by the end of the year. We're not entirely sure. But I think you can see the determination we have as a group to all the time improve what we're able to offer. And indeed, it's a great pleasure working with the Alex charity that have really supported us through this process. So I think this is our final slide. We'd just like to mention here a few of our colleagues. There are many colleagues, in fact, but a few of them who have supported us through this. As I said, from neurogenetics, metabolic, neuroradiology, neurology, and so on. And it's been a great pleasure, and it is a great pleasure to work with colleagues in and around Queen Square. So we very much hope you enjoy the weekend. It is a great delight to work with the Alex charity. We hope to be able to bring you, we hope, good news about the commissioning process, but we await for that. And on that note, we wish you a very good day. Thank you.
Thank you.